Morning, everybody. And there's been a lot of change, a lot of advances in podocytopathies and minimal change disease. So I thought I would just discuss some of the advances this morning. So as we're aware, minimal change disease and FSGS are both diseases of the podocyte. We know that. We see diffuse food process effacement on electron microscopy. We know with podocyte ablation models, we can develop these phenotypes of minimal change disease or FSGS. And in human disease, what we think is happening is that there's a variety of injuries. Now, we'll be talking about anti-nephrin antibodies, so that would be one injury. But there are other injuries that affect the podocyte. And depending on the genetic background and the response of the podocyte, we can either go down a pathway of sublethal injury and repair, which is the phenotype of minimal change disease. Or with more significant podocyte injury, we can have detachment and podocyte loss and head down a pathway of FSGS. So significant overlap between these two clinical phenotypes. Now, for many years, minimal change disease has been considered an abnormality of T cell function. And this is actually a paper that our group presented this year. So this is a 24-year-old man who had minimal change disease secondary to a defect in T cell regulation. So he has a condition called IPEX syndrome, where he developed multiple autoimmune diseases from a young age. And genetic testing subsequently identified a mutation in the promoter of the FOXP3 gene. And this leads to an absence of regulatory T cells. So he had a breakdown in peripheral tolerance with increased T cell activity. His kidney history is particularly interesting in that when he was age 12, he developed nephrotic syndrome. He was managed here at Children's Hospital, and a biopsy showed membranous nephropathy. He was treated with cyclosporin, RAS inhibition, and went into remission. He had a second episode of nephrotic syndrome at age 16, again responded to cyclosporin. And then at the age of 24, we saw him in clinic here for his third presentation of nephrotic syndrome. And this time it was a little different. He had acute kidney injury. It was more sudden onset. His albumin was 2.5, 6.6 grams of proteinuria, and he underwent a kidney biopsy. And so maybe not surprisingly for this talk, he had minimal change disease. If you have sharp eyes, you might notice a little bit of mesangial expansion on light microscopy, which we felt was some background diabetic kidney disease from his long history of insulin-dependent diabetes. But he has diffuse food process effacement. And notably on his immunofluorescence, so you can see the gain has been turned up high here, but you can see these little dots or little speckles, which has been called podocyte dusting or punctate IgG. In this case, not done as sort of routine clinical care, he had confocal microscopy done on frozen tissue, looking, again, demonstrating this kind of punctate IgG staining. We're able to, using an anti-nephrin antibody, show punctate nephrin staining. And when these two were merged, you can see this yellow color suggesting that the IgG, or showing that the IgG and the nephrin co-localize. So this is just another example to show what we're talking about for the anti-nephrin antibody. So again, this is a immunofluorescence for IgG. And again, you can see these little dots over podocytes throughout. And this is the podocyte dusting. Here we have diffuse food process effacement. And as Ram educated me recently, this kind of podocyte or ballooning of podocyte cytoplasm has been associated with anti-nephrin antibodies. So just to remind ourselves what nephrin is. So nephrin is the major component of the slit diaphragm. So here at very high power, you can see nice food processes. And in between them, we have these slit diaphragms. So we typically don't see these clearly on electron microscopy. And this image just shows what the slit diaphragm may look like in sort of 3D. And the red bars are the nephrin proteins coming out from each food process kind of interlocking. And we can see that nephrin is the major component of the slit diaphragm. Importantly, it's not the only component. We have Neph1, we have some other fat ones, some other proteins that cross the slit diaphragm. And obviously these proteins signal and interact with proteins in the actin cytoskeleton and other podocyte proteins. So the anti-nephrin story actually goes back many years. So this is about 40 years ago when this paper was published. So this Japanese group developed an antibody, which they called antibody 516. They immunized BALB/c mice with kind of ground up and collagenase digested rat glomeruli and identified or isolated the immunoglobulin. And they injected this into rats. And what they found was they got almost immediate proteinuria with diffuse food process effacement on electron microscopy. And on immunoelectron microscopy, they were able to show that the antibody, they called a monoclonal antibody, but it's not, I think, quite a monoclonal antibody as we would understand it, binding at the slit diaphragm. And this happened as early as 2 hours after infusion. 10 years later, 1999, this monoclonal or this antibody 516 was actually identified as being directed at the extracellular domain of rat nephrin. And this was done by David Salant in Boston University. And as you recall, Dr. Salant identified the anti-PLA2R antibody in membranous nephropathy. We know that nephrin is mutated in congenital nephrotic syndrome of the Finnish type. This is an autosomal recessive disease. And the first evidence of human anti-nephrin antibodies causing nephrotic syndrome was in patients, sort of young, very young children who were transplanted after congenital nephrotic syndrome. A subgroup developed nephrotic syndrome due to alloantibodies against what they see as foreign nephrin. But the big advance took another 20 years, and this was a paper published in JASN in 2022 from Astrid Vine's group in the Brigham. And she looked at serum that was stored from the Neptune cohort, looked at 41 children and 21 adults with minimal change disease. And she was able to identify anti-nephrin antibodies in the minimal change disease group, but not in the membranous group or in healthy controls. And when she looked at the overall numbers, about 1/3 or 29% of these patients had anti-nephrin antibodies. Now, a couple of caveats that these patients were enrolled in the study at various phases. So some had active nephrotic syndrome, some had already had treated nephrotic syndrome. And as we'll talk about, there's some discussion about the assay that's used to measure anti-nephrin antibodies. But she was able to show that there was some correlation with activity, that the antibody seemed positive during active nephrosis and went negative during remission. And again, on a subgroup confocal microscopy, showed co-localization of the punctate IgG and nephrin. A big advance with much bigger numbers was this paper published last year in the New England Journal from the Hamburg group. So they looked at 357 adults with stored serum. They looked at 182 children with stored serum, and they measured the anti-nephrin antibody by a different assay. So I think this is important, that this is a sort of a more complex assay. It's a hybrid assay. They first do an immunoprecipitation step using a column to isolate IgG, and then do an ELISA on this. So this may be a more sensitive form of measuring these anti-nephrin antibodies. So this might be the most important talk off the slide. This kind of gives the summary of what they found from a frequency or prevalence point of view. So in this side is adult minimal change disease. What they found was that about 44% had antibodies to anti-nephrin. But if you look at those who were nephrotic and had not been treated, in adults, 69% had, or 2/3 had anti-nephrin antibodies. And this number was even higher in children. So overall in children, 52%. But if you looked at those, again, who were nephrotic prior to immunosuppression, they found 90% were nephrotic. If we look at controls, the controls were almost all negative. There was one membranous patient and a few patients with membranous with FSGS. Overall, they found 9% of patients who had an FSGS pattern actually had anti-nephrin antibodies. They were able to identify some correlation again with anti-nephrin antibodies and disease course. So without going into this in detail, sort of if you just look at this first patient here, number 1, when it's red, it's positive. So the top bar is positive antibodies with positive proteinuria. When they went into remission, the blue bars, they had anti-nephrin antibodies were negative. They relapsed, both became, the anti-nephrin antibodies and proteinuria came back in remission, again, both negative. And they were able to show this for a number of different patients in both adults and children. So the same group then expanded their number of children. So they took the group that was in the New England Journal and they added another 150 odd patients to give a total of 333 patients. And again, what they saw was overall in patients who were either steroid sensitive or steroid dependent, somewhere around 80% of these children had anti-nephrin antibodies. And if you look at the steroid resistant group, this fell away off, but still about 18% of patients who were steroid resistant had anti-nephrin antibodies. And notably, this group was a group that responded to other lines of immunosuppression. So steroid resistant, but responded to calcineurin inhibitors or mycophenolate or rituximab or other things. The multi-drug resistant group, they did not find antibodies in this group. And then just one other example of sort of frequency. This is a Chinese population with diffuse podocytopathy. Again, large numbers, 596. These are adults. And when they looked at the numbers overall, they found about 50% of patients with diffuse podocytopathy had anti-nephrin antibodies. And when they broke this down into minimal change disease and FSGS, minimal change disease, they found about half the patients. But in this group, surprisingly, there was quite a high proportion of the FSGS group. Actually, they found anti-nephrin antibodies. Of note, they also looked for IgG, but also IgM, and they found IgM antibodies in about a third. Okay, so sort of stepping back, we always have to ask ourselves the question, is this just an association? Are these antibodies produced when you get podocyte injury and it's kind of a secondary epiphenomenon, or are these causal? So there is some evidence. We discussed some of the, we discussed the 516 antibody, the sort of passive transfer. There have been some other passive transfer experiments. In this New England Journal article, the Hamburg group again described an animal model where they immunized BALB/c mice with recombinant murine nephrin. And what we see here is that these mice, after a couple of weeks, developed anti-nephrin antibodies. And again, once they developed the anti-nephrin antibodies, then pretty quickly they developed proteinuria, which was not found in the controls. When they were biopsied or sacrificed, then yes, they had diffuse food process effacement and able to show IgG and anti-nephrin antibodies. Again, you can just see this sort of yellow coloring showing co-localization. They also took this a step further and did some proteomic analysis, looking at a number of podocyte proteins, and also looked at phosphorylation of nephrin. There's been an association of increased phosphorylation of nephrin and nephrin redistribution and nephrin signaling, and they found increased nephrin phosphorylation in these animals. This was a letter to JCI just published this year, which I thought was quite interesting. So this is a passive transfer model. So they actually took antibodies from a woman with minimal change disease. She had severe disease. She underwent plasma exchange. They were able to isolate and purify the anti-nephrin antibodies. They found that the antibodies cross-reacted with rabbit nephrin, not so much mouse or rat nephrin. And when they injected the nephrin into, or the anti-nephrin antibody into a rat model, they were able to demonstrate that the rabbit developed proteinuria at a rapid stage, again with diffuse food process effacement. And they were able to show that this was not due to serum sickness because of the absence of C3 or rabbit immunoglobulin on immunofluorescence. Okay, so we've described that anti-nephrin antibodies are common in children with minimal change disease and occur roughly 50% or 60% of adults with minimal change disease. What about the transplant situation? So clearly most patients with minimal change disease don't reach transplant, but some are steroid resistant and some with diffuse podocytopathy have an FSGS phenotype. So this is a study from 5 centers in the States and abroad. They looked at 39 patients who had diffuse podocytopathy that reached end-stage renal disease and presented for transplant. They had pre-transplant stored serum. They used the standard ELISA from the Vines lab. And they also had biopsy, post-transplant biopsy tissue on 24 patients. So these were adults, about 35 years, and about 2/3 were deceased donor kidney transplants. So as expected, about half the patients developed recurrent FSGS, something that we see commonly with FSGS. So here's the sort of the key point. So when they looked for anti-nephrin antibodies, of the 2/3 of the patients who developed recurrent disease, about 1/3 of them had anti-nephrin antibodies. So looking at that the other way, that means that 2/3 did not carry anti-nephrin antibodies. So, but a significant proportion of these patients had anti-nephrin antibodies. They were not found in the group that did not recur, or if we look at that the other way around, in all the patients who were anti-nephrin antibody positive prior to transplant, they all had recurrence. And if we look at this recurrent disease population in the anti-nephrin positive patients, we found that they were younger, they had more severe and earlier recurrence, and they actually had history of prior graft loss. So about 1/3 of patients in sort of recurrent diffuse podocytopathy or recurrent FSGS had anti-nephrin antibodies. The other thing this paper showed, which I find interesting, was looking at the pathology. Off the recurrent group, they were able to show punctate nephrin staining, so nephrin redistribution in about 3/4. And they found different patterns of pathology. So in 5 out of 16, they found what maybe we might expect. There were anti-nephrin antibodies and anti-IgG, the sort of so-called podocyte dusting that co-localized. But in one of the group, there was no co-localization. Again, possibly suggesting that there might be a different antipodocyte antibody involved in that patient. And then in 6 out of the 16, again, there was punctate nephrin redistribution, but all these patients had negative serologies. So again, raising the possibility of a different factor, possibly a non-antibody permeability factor in some cases of FSGS. Again, highlighting that there are multiple different ways, multiple different injuries that can lead to a pattern of FSGS. So this question about can there be other antibodies other than anti-nephrin? So this is a biopsy study from an Italian group, and they describe anti-slit diaphragm antibodies. So again, some of these co-localized with nephrin, but importantly, not all. So they had 162 kids. So in this group, only 30% had anti-slit diaphragm antibodies. But remember that most children are not biopsied. So this is a highly select group that actually underwent biopsy. And in adults, they found kind of like similar numbers to the Hamburg group. About 2/3 of the minimal change disease patients had anti-slit diaphragm antibodies. But when they looked for co-localization with nephrin, what they found is about 80% of children had co-localization in this group. So again, the majority were consistent with anti-nephrin antibodies, but in adults, only 44% co-localized. again suggesting that there may be other non-anti-nephrin antibodies associated with minimal change disease in adults. So what are these antibodies? So without going into detail, there's actually been a number of other antibodies that have been described in minimal change disease, mostly in cohorts of children. So as we mentioned, nephrin occurs in about 80% of children. These are two anti-proteasome antibodies that have been described. This one just described in Jason in 2025 occurred in 50% in this cohort. They were able to show co-localization of IgG and the antigen on the biopsy using confocal microscopy. They were able to show that injecting some of these antibodies into rodents causes the disease. In this one, there's an immunization model where immunizing bulb C mice with murine PSMA1 developed the disease. So there's certainly supportive evidence for a number of these antibodies. And as we can tell, we're still at kind of early stages finding out just how pathogenic each of these antibodies is and whether we get one or more of these antibodies in individual patients. So just summarizing the pathogenesis of diffuse podocytopathy. Obviously, it's a complex pattern. It's not as simple as saying that anti-nephrin antibodies cause minimal change disease. We described our patient who had a impaired T-cell regulation. There's a lot of evidence for increased T-cell activity or upregulation in minimal change disease, a variety of cytokines that may either directly affect the podocyte or enhance antibody production by B cells have been described. We all know that sometimes minimal change disease is triggered by allergies or infection. We saw this with COVID vaccines, with Hodgkin's lymphoma. And sometimes infections may activate the innate immune system and more directly affect the podocyte. And then several genes have been described that increase the sensitivity to minimal change disease. One example is an HLA allele, which may associate with some of these antibodies. And then a range of antigens or proteins have been described in the podocyte, and data on most of these playing a role in the podocyte response to these injuries, and again, with sublethal injury leading to this minimal change phenotype. So in summary, for anti-nephrin antibodies in diffuse podocytopathy, I think the exciting things, maybe this will be like PLA2R, the way we're using that we can consider this as a diagnostic tool. It may allow us to guide the initial therapy. We're currently using steroids, but maybe we can use other agents. We know that it occurs about 80% of childhood nephrotic syndrome, mostly steroid sensitive, maybe 2/3 of adult onset minimal change disease. There does seem to be some correlation with disease activity and also possibly with relapse. Maybe it allows us to guide some B cell targeted therapies, and I'll talk about that very briefly. It may help with transplant assessment, and I just emphasize that it's actually the minority of patients with recurrent FSGS have anti-nephrin antibodies. The one paper I described about 1/3. Discussing with Dr. Raella when he was here, I think he mentioned about 20% of the Tango cohort with recurrent FSGS had anti-nephrin antibodies. So kind of a range of numbers. So there are lots of, or certainly several other things that are likely causing FSGS and recurrent disease. There are some, I think, important things to think about before we get too excited about anti-nephrin antibodies. So one is assay variability. So there are multiple different assays out there. There's been quite a few cohorts now described with really a big range of frequencies of anti-nephrin antibodies in minimal change disease. The Hamburg group may be the most sensitive assay, but it's actually a very complicated assay and difficult to do, and it's uncertain to me if that is potentially a commercial assay. So a number of false negatives have been described. Obviously, with any ELISA, then defining cutoffs is important. So there seems to be some geographical differences in frequencies. Again, I don't know if this is real or whether this is related to the different assays that are used in different parts of the world. I think there is some emerging evidence of pathogenicity for these antibodies. But as I mentioned, there are also multiple other podocyte antibodies described. And so I think we're continuing to learn about which role each of these plays in more time. So I'm going to talk just very briefly about the treatment of minimal change disease. When you ask AI to produce an image of somebody with minimal change disease, they do a pretty good job. They show the peripheral edema. But as you can see by the size, we've got a little bit of hallucination. Either he's huge or the parents in the sofa have shrunk. So the joys of using AI. So in children, I'm not going to go over this, but new guidelines were just published a month ago. KDIGO guidelines for the management of nephrotic syndrome in children, but essentially it's very similar to in adults. We still start treatment with adults with steroids. Adults respond very well to steroids. So if this is, an anti-nephrin antibody disease in 2/3 of patients, why would you respond so well to steroids? Obviously, steroids do different things. They act on the immune system, but Dr. Shankland has shown that they act directly on podocytes as well. The big problem that we struggle with steroids is the relapse rate. So it may be that they're effective in the short term, but without getting rid of the potential antibodies, the disease tends to relapse 50 to 60% of the time. So I'm going to skip this about other options, but I wanted just to discuss briefly B-cell targeting therapies in minimal change disease. We're all familiar with more commonly using rituximab for either steroid-dependent or frequently relapsing nephrotic syndrome. So this NEMO study was described now 11 years ago, showing in the minimal change disease group a big drop in recurrence or number of relapses per year in these patients from 3 down to close to 0. So a big improvement. But this is the most recent and largest data. So this was published this year again in JASN. So this looked at 183 adults from 30 centers in Europe and North America and Asia. It's described as an induction study, but it's really an induction study of rituximab plus other immunosuppression. So to put patients had active nephrotic syndrome, they were treated with rituximab plus something else. So this is not rituximab monotherapy. And they got a range of doses. And what we can see at 6 months is that in the steroid-dependent and frequently relapsing group, they did very well. Now, you might expect some of this with steroids and calcineurin inhibitors, but at the 6-month data, we were seeing kind of complete remission rates of 82%. I think what is interesting is in the steroid-resistant group, so 39 patients with steroid resistance, using rituximab, there was still an 18% complete remission rate at 6 months, and about 50% had a response, again, complete and partial remission. And I think what is most interesting is giving us sort of better data about what the relapse rates are with using rituximab. So this is a highly selected group that are all relapsing. So they're in that 100%, they're in that sort of group of patients with minimal change disease or FSGS that frequently relapse. And when they were given rituximab, approximately 50% relapsed following this. So half the patients never had another episode. And in a subgroup, they were treated with maintenance rituximab. So after that first course, they were given consolidation doses at 6 months or further. And in that case, about 30% relapse. So we're seeing that in certainly a group of patients anti-B cell therapy is quite effective at presenting relapses. And I think this is the last slide. Oh no. Well, just to mention, there's a couple of studies being done currently. One is called the Turing study, looking at rituximab versus placebo on top of standard of care prednisone or prednisolone to see if you can decrease relapses. And another called Riferens. And it's interesting because they're giving rituximab with low dose prednisolone and over a short duration of around 9 weeks to see if rituximab can limit steroid exposure. But the last slide is really the question of, can we use rituximab monotherapy for induction? So giving steroid-free monotherapy. So this is done in patients who anti-nephrin antibodies or other antibodies were not measured. And it's really just 2 small case series. There's really not a lot of data out there at the moment. But in these case series, which might be highly selective, in this group, these were patients who had contraindications for one reason or another to steroids, and all had a response. This is proteinuria on this axis. You can see it takes quite a while. So in many of these patients, it was taking 3 months to get down, as opposed to 3 to 4 weeks that we often see with steroids. And in this series of 9 patients from China, 8 out of the 9 had a complete remission with rituximab monotherapy. Some went into remission quickly, but some took a couple of months. There's one 9 months, 3 months. So again, a hint that maybe it takes a little bit longer with rituximab monotherapy. So in summary, anti-nephrin antibodies are commonly found in minimal change disease and in some patients with FSGS, again, sort of demonstrating the overlap in these 2 clinical phenotypes. I think we're moving away from, or gradually anyway, from these descriptors and hopefully moving to an etiologically based classification for these glomerular diseases, starting to use the term autoimmune podocytopathy, maybe diffuse podocytopathy, or hopefully being more specific when we have better data or better able to measure these antibodies, such as an anti-nephrin podocytopathy. And I think there's a new era in the treatment of podocytopathies coming. I think the big thing we need is clinical availability of the anti-nephrin antibodies. But I'm expecting that will be soon. So thanks for your time and happy to answer any questions.
Thank you so much. Actually, that was a wonderful talk, and definitely it's gotten us all up to speed, I think, with where we are in terms of these autoimmune podocytopathies, particularly minimal change disease. There is some discussion in the chat ongoing. Galyuan actually brought up quite a few questions, some of which you touched on towards the end. Will patients with anti-nephrin antibody respond to rituximab, which I think you spoke on, as well as can it be used? I'm assuming anti-nephrin antibody measurement be used in a similar fashion to PLA2R and membranous nephropathy. And I think the last question, though, I'm curious, is anti-nephrin antibody test available here at UW? It sounds like you hit on some of that, but yeah, how would we go about testing for that currently?
So there's no clinical test available, is the bottom line.
Gotcha.
The patent has been bought by Euroimmune, which is the company that actually does the anti-PLA2R nephrin, or the anti-PLA2R antibodies in membranous nephropathy. The difficulty is there's a lot of variation in all of these assays that are done. The simple ELISA that are done in different labs are done in different ways with different fragments of nephrin produced in different cells. And the hybrid assay from the Hamburg group, which may be the most accurate, is kind of like a complex assay. So there is some delay, I think, in the development of a commercial assay. If you want to measure it today at UW, it's not straightforward. Some research labs have kindly done a few for us when it was kind of in development. I've sensed a little bit of cooling from those labs now that they don't really want to be bombarded because everybody around the States wants to measure their anti-nephrin antibodies. So I think we're predominantly waiting for a commercial assay.
All right, wonderful. Ram, I see you have your hand raised there. Would you like to comment or have a
Yeah,
question?
thank you. Thank you. Great job, Ashley, reviewing this very rapidly evolving literature. One comment and maybe a question that you may not have the answer for, but the comment was, in both the, Virginia Savin's permeability factor experiments in the 90s and also the experiments with the 516 antibody, they could see changes very rapidly, right? So within an hour, they're already seeing changes in permeability, foot process effacement. And also the 516, they basically showed that the monovalent Fab was not active. But the Fab2 fragment without the FC could still cause proteinuria. So it again suggests like maybe some cross-linking functional aspect is occurring, maybe to interfere with nephrin signaling. The question I had, I guess, is really related, we may be going to a paradigm like membranous where there are many, there's a dominant antigen and there might be minor antigens. It still doesn't make sense to me why some of those antigens would be targets because they're intracellular, right? Podocin is entirely intracellular, some of the other molecules you mentioned as well. So I was curious what you thought about that.
Yeah, I think the other thing is like some of these other antigens are also not exclusively found in the podocytes. They're very widely expressed in really all cells. So why do they target the podocyte? So I don't know the answer. Are they secondary phenomenon that something else is injuring the podocyte and these intracellular antigens are somehow moved to the surface or somehow accessible? I don't know the answer, but yeah, very good point.
I mean, I guess there's precedent with that with ANCAs too, right? I mean, there's some exposure of those antigens, so maybe there's something that like that going on too. So
Yeah.
thank you.
All right, and similarly, in the chat, Leah mentions where does the permeability factor fit in here, which kind of touched on a little bit, but and do
Yeah.
we know the IgG subclass?
I think I would just say it's multiple permeability factors. I think still at this stage, I don't think there's one permeability factor. And I think anti-nephrin is one of those, but I don't think they're all antibodies. I think we'll find other things as well.
All right. Well, thank you. For the sake of time, I want to be fair to all our speakers. And so I think if we have any other questions or comments, we can continue in the chat and we'll move forward with our last speaker for today.